Go back to what I said this morning before we broke for lunch. If you find yourself in a quandary about ferreting out ADHD versus versus OCD versus oppositional defiance, things along that particular line, possibly bipolar or DMDD, then that's a lot to take on, because there's significant amounts of symptom overlap. One of the best ways to ferret that out relatively quickly is to do a medication challenge. You're not going to do a medication challenge with oppositional defiance or DMDD. You could put the kid on an antipsychotic and the kid will calm down, but that may not go to the cause and what's driving the core problem. So I want to look for medication groups that have bona fide efficacy in moderating the symptom presentation, okay? And in bipolar disorder, we know what that is. Those are mood stabilizers. The point is, these meds work in these disorders. Any kid with mania is going to get better on Depakote. If he doesn't, he'll go to lithium, and I'll guarantee you he's going to get better if it's dosed appropriately. It works that well. These meds also work well. Medication challenge. ADHD, does the kid respond? Does he calm down a bit? Does he settle down? And I'm just using he as an example. Is he less impulsive? Check with parents. Is he sitting, focusing? You'll see demonstrable difference in maybe 1 hour on a psychostimulant. 1 hour. If it's short half-life, it's going to take effect, you'll see a different kid. Now, if it's aggravated by a conduct problem, that's another story. But you'll still likely see some improvement. If not, we wouldn't say that the meds are in the 80 to 90% effectiveness range. But they are. That's not Joe saying it. It's true. So, ADHD is an executive functioning problem. So now I've moved from the limbic system on up to the prefrontal cortex area of the brain. That is the temporal lobe area. We're now working right there. ADHD, distractibility, and inattentiveness, these are executive functionings. These are cerebral in nature. So, whether it be at school, work, home, or social settings. So, for medication to be effective, it's got to be taken every day. It's only going to control symptoms as long as they are taken. Why do I bring this up? Because parents want to ease their way into medication, and they'll ask me, well, does he really have to take it every day? You know, they have a fear about stunted growth, right? A fear of dependence. All of those are bona fide fears, but I have to remind them that if the child has no history of substance abuse, that's not a major concern right now. So the symptoms that are presenting are what's important to medicate. And if we're going to go the medication route, then it's going to be taken every day and on a regular schedule. So there are no long-term lasting effects once the drugs are stopped. So this is what parents fear. Stunted growth is one that comes up quite often. That was long ago dispelled. So if the medications are stopped, no residual effects. Nothing at all bona fide. But if medication is stopped, keep in mind, if symptoms will return, assuming the child's not getting behavioral treatment or has figured out a management plan or organizational plan, then that means that symptoms will return similar to before medication was initiated.